Hello, everyone, and welcome. I'm Annie Njanja, a communications specialist at Center for Epidemiological Modeling and Analysis, SEMA, and the session's moderator. We appreciate you taking time to join us. So, in honor of HIV/AIDS Awareness Month, today's session will focus on how modeling helps guide and improve HIV response efforts. Our lead for this session is Dr. Kennedy Mutai, a senior research associate in infectious disease mathematical modeling at the University of Bristol, UK. Dr. Mutai has a wealth of experience having worked as a statistician and modeler in research and policy at health research institutions and government agencies in Kenya. He has also provided technical support to inform policy and programming for the HIV response in countries within Eastern and Southern Africa. In today's session, he will demonstrate how mathematical modeling can guide HIV prevention and treatment decisions, explain the importance of capturing epidemic heterogeneity and key populations, and illustrate how modeling outputs can be translated into actionable guidance for policymakers. We encourage everyone to stay muted, listen actively, and engage during the Q&A session towards the end. Also, feel free to post questions on our chat too, and we're using also the chat to share more information about Dr. Kennedy and SEMA. Without further delay, I welcome Dr. Mutai to take us through the session. Welcome, Dr. Mutai.
Thank you very kindly, Annie, for your warm and kind introductions. And also thank you to SEMA for inviting me to your seminar series for this month, and thanks to the participants as well for joining in. At today's session, I'm going to present on using modeling to inform public health impact in HIV response, and I'm from the University of Bristol. So as an overview, I'm going to talk a little bit about ourselves here at the University of Bristol. I'll then speak about why HIV modeling matter. I'll also discuss about the importance of capturing heterogeneity in HIV models, as well as capturing key populations. I'll speak about the pipeline through modeling to meaning or modeling to impact, if you'd like. And then using a few case examples, I'll discuss about the impact of funding cuts on HIV response, and I'll give some conclusions. So we are the Global Epidemiology and Modeling Group at the University of Bristol. As you can see in that deck, those are our researchers comprising of postdoctoral researchers as well as PhD students in mathematical modeling. So we have mathematical modelers, epidemiologists, as well as health economists. We do collaborate with various universities across the world, as well as national and international stakeholders. And since 2020, we've had detailed research in about 44 countries, as you'd see in that chart, shaded red. Those are the countries that we've done research since 2020. Our group is led by Professor Peter Wickman. In terms of the key areas of focus that we do as a group, we use data analysis and systematic reviews and mathematical modeling to improve evidence-based for interventions. And this is across different country contexts and across different population groups. We also do work related to the importance of vulnerable key populations and risk behaviors, and that's looking at various key populations, their risk factors, and how that speak into HIV and viral hepatitis C transmission. We do policy relevant work that have informed some of the national as well as global key documents, including WHO and UNAIDS guidance. And we also do work on the role of structural factors in HIV and viral hepatitis C transmissions, structural factors like homelessness, incarceration, stigma, and discrimination, as well as violence, among others. So, as a way of introduction, as Annie has mentioned, that December is the world. Is someone saying something? A question?
No, continue. Sorry about
So December, we mark the World HIV/AIDS Awareness Month. And as we mark this day, it is crucial of this, and the 1st of December was the World's AIDS Day. And as we mark this month of awareness, it's crucial to note that there has been decades of notable progress in the HIV response. And this has largely been driven by global solidarity and strong advocacy through the community and government engagement, which has really been key and central to that success. And this has enabled a massive scale up of key interventions made possible through that collaboration. So, why HIV modeling matters? We know that there's been great progress that has been made in the HIV response over the years. And just highlight this. So over the years, since the mid-90s, when there was a peak of the epidemic, where incidence and new HIV infections was really high, and this has kept on declining, showing great progress. However, incidence still remain high overall, and in some regions and in some populations. In this chart from the UNAIDS, it shows where the current new HIV infections has reached in 2024, but then in terms of attaining the targets for 2025 and 2030, that is still a mile, like it's still further away for countries and globally to be achieved. And so incidence still remain high. We know that there are vulnerabilities that occur at different levels, different population, different societal environment. And there has been an ecosystem of available interventions that have evolved over time with prevention tools that have increased, including pre-exposure prophylaxis, long-acting ART, or opioid agonist therapy, and so many other innovations. And so, therefore, it's really crucial for HIV modeling to inform and continue to estimate the current as well as predict the future burden. Also to keep track of the progress towards the targets, such as the 2030 targets for eliminating HIV as a public health threat, and as a tool for advocacy used by communities as well as civil society organizations to be able to demand for accountability for results and as well as to demand, high funding for the HIV response. And so that's why modeling comes in. I'll speak a little bit about the importance of capturing heterogeneity in HIV models. So HIV transmission, as you would be aware, is not uniform. There's it's high in some of the specific populations, in some of the sexual or social structural networks, but also there's varying access levels to different interventions, be it ART programs and all other interventions. The access is always not uniform. And so models need to capture the critical aspect of that in the epidemic dynamics. We have to ensure that we incorporate heterogeneity for robust model estimates to have estimates that are really informed by what we are seeing from the heterogeneity observed in the populations. It also helps design and target interventions effectively. For instance, which populations group to target, which access to care levels. If you looked, for instance, about the cascade of care, treatment, diagnosis, viral suppression, which access care levels do we need to access? And unless we capture heterogeneity well, it will be difficult to assess that. And so I'm going to give an example of some of the work that we did to assess some heterogeneity issue. And we asked ourselves whether homelessness was an important factor in HIV transmission among people who inject drugs in South Africa. And this work that's under review almost getting into publications. When we looked at data, we found that those who were homeless had higher or increased levels of sharing needles. And for people who inject drugs, if there's a higher proportion of people sharing needles, that equates to higher transmission in that population. But also we found that homeless people who inject drugs had lower access to opioid agonist therapy, which is an intervention to reduce HIV infections. And so if we assumed homogeneity across homelessness status, then that won't be able to capture it. But because of that, we are able to parameterize and calibrate our model to be able to capture that heterogeneity. Moving on further to the focus on key and vulnerable populations. So key populations are central to HIV transmission, and these are populations that are a considerable adult, that they have a considerable adult new HIV infections. And just giving an example of what was published recently by Eileen from UNAIDS, showing the distribution of new HIV infections globally and in some of the regions. In Eastern and Southern Africa, this paper illustrates that the key populations comprised about 22% of the new HIV infections in Eastern and Southern Africa, and about a third in West and Central Africa. But globally, in all the countries, that goes up to 55% and even higher in countries outside of Sub-Saharan Africa, showing that the focus of key populations is important in the HIV response. And why is this so? Key populations, they engage in higher risk behaviors, including unsafe or rather risky sexual behaviors, risky injecting behaviors for those who are injecting drugs, and so on and so forth. They also do experience barriers to accessing treatment and prevention services, and these barriers are often sometimes exacerbated by some of the structural factors, including punitive laws. And so it's important to focus the key populations in HIV modeling to be able to inform targeted prevention and enhanced treatment. And these will ensure that the needs of key populations are met and their risk are well captured in the model. But also importantly, this is necessary to control the epidemic overall, because you cannot control the epidemic if you are leaving some of the populations unattended. And there is always overlap between these populations, and so it's necessary to control the epidemic overall. Moving to a translation pipeline, and this is based on my experience over the years about what I view in, from where I sit about a pipeline in terms of the translation of modeling to impact or translation of models to meaning. And so the first thing is to identify or define a problem. What is the public health priority for that matter? It could be, for instance, trying to evidence HIV elimination in a country, say Kenya, and that could be your priority public health problem. The next thing is to ensure that you tailor that and design that to context-specific realities, and this is a coordinated effort with stakeholders, government agencies, community people, health sector, to be able to understand what are some of the context-specific realities. It could be context-specific things around cascade of care for countries, which will always differ from one country to the other. Then it's crucial to integrate that into local epidemiological and health system data. And this is what will drive your model. You have to look at data. A while ago, I presented about some of the analysis that we did just as an example of what we did in South Africa. And it's important to integrate to get data that you'll be able to use to parameterize as well as to calibrate data, and I'll speak about that later. Then you'll want to do some scenario analysis and explore what are the current levels of interventions and what that entails in terms of looking at some of the specific HIV outcomes, e.g., for instance, HIV infections or AIDS-related death. And you can explore additional scenario analysis to say, what if we are able to scale up some of the interventions to attain some of the 2030 targets? What would that mean in terms of reduction in HIV infections? Then we have to engage policy people and work with ministries, donors, as well as community to ensure that the models and the results that we are generating speaks into and align well with the policy and the policy people. And we have to do a loop of implementation as well as feedback to see how is that progressing. Are there new additional data that you need to adjust your model and so on and so forth? So that's what, in my own assessment, I'll say is a translation pipeline. I'll move further to give a few case studies and speak a little bit about the impact of funding cuts to the HIV response. To start with, I'll speak about the impacts of cuts in US PEPFAR funding for HIV pre-exposure prophylaxis in sub-Saharan Africa. And this is a modeling study that we recently published, led by Jack Stone, myself, and Peter Wickman from our group, among other of our collaborators, and recently published in the Lancet HIV. And so PEPFAR accounts for over 90% of the global initiations to oral pre-exposure prophylaxis, with key populations accounting to over a quarter of that provisions. And as majority of you would know, that early this year, the US government had a stop order on all foreign aid. And this resulted in pausing until further notice some of the interventions for key populations, which included PrEP. And so we aim to estimate the impact on HIV infections that could occur in sub-Saharan Africa over the next year if this provision of PrEP through PEPFAR is ceased. And we look at different population groups, including female sex workers, men who have sex with men, people who inject drugs, as well as transgender women. To do this, we developed a static model to estimate the short-term impact of ceasing PEPFAR funding. And for each country that we model, we first started by estimating the PrEP coverage, which is the proportion of the HIV-negative people receiving PrEP. We then looked at primary infections, and that's the number of additional HIV infections that would occur if that provision is ceased. We also looked at secondary infections that could occur as a result of these primary infections over 5 years. In terms of the data that we use to parameterize this model, and this is the data that we use to make sure that this model is able to do the job that needs to be done, we looked at the number of those who are receiving PrEP between July to September 2024. We then used data on population size, HIV prevalence, and incidence of people who inject drugs derived from various global and regional systematic reviews. And where that was missing, we used a pooled estimate across low and middle income countries. And we used data on the effectiveness of PrEP in reducing HIV transmission from literature. In terms of the coverage of PEPFAR-supported PrEP, by the end of 2024, PEPFAR was supporting about 206,000 members of various key populations to receive PrEP. And this differed across these population groups, high in female sex workers, about 137,000, and low in transgender women, about 3,700. As you can see in the charts provided here, MSM, FSW, PWID, and TWG, the coverage of PrEP differ across these countries. And so there are countries with higher coverage and some countries with low coverage. Overall, this coverage is about 4.4% among all the HIV negative key populations, low among PWID, high among FSW. When we analyze the absolute increase in new HIV infections, we estimate that removal of PEPFAR provision over the next year will lead to about 5,700 additional new infections, higher among MSM as well as FSW. And this is higher in some of the countries as shown in this chart. This chart shows the additional new HIV infections that would occur if you remove PrEP in different countries. And this shows the cumulative and the contribution of that cumulative from each country. So there's heterogeneity, of course, in these countries. There's these differences that is based both on the incidence levels in these countries as well as the coverage of PrEP in these countries. In summary, what we can take home from this is that the provision that is being removed is really large, about 200,000 populations that have stopped PrEP as a result of that. And this could lead to an additional 5,700 new HIV infections, with that being about 2.1 increase relative to what it would be if that provision was not removed. This impact may look that it's limited, but remember, it's only 4.4% of HIV negative members of the key populations who are receiving PrEP. And so there's urgent need to mitigate that funding gaps, but also importantly, there's a need for additional investment to increase PrEP coverage and its population level impact. I'll quickly also mention about some of the work that we've done, and this is on modeling the impact of PrEP for funding cuts on opioid agonist therapy, OAT, and needle and syringe program, NSP, on HIV and viral hepatitis transmission among people who inject drugs. And this, again, work myself, Jackson, and Peter Fickman from the University of Bristol and other collaborators. This is work under review from one of the journals, and we recently presented this in one of the conferences. Same background as I did mention earlier on about these funding cuts. And we know that the US government funds a large share of opioid agonist and needle syringe, and these are programs that have been shown to be effective in reducing HIV and hepatitis C transmission among people who inject drugs. And this pausing of foreign aid impacted this. There was a cessation of PEPFAR funding cuts for OAT, and there was a disruption in NSP. And with this, we aim to assess the potential impact of this reduction in both OAT and NSP provision on HIV and hepatitis C transmission. I'll just speak about the methods overall, but then in terms of results, I'll only focus on HIV because we are focused today is on HIV. This was done for 9 countries where PEPFAR was funding OAT. We developed a static mathematical model to estimate the short-term impact of that disruption in 9 countries, shaded green in this map that PEPFAR was providing OAT. And to do that, we first estimated the coverage, that is the proportion on PEPFAR-funded OAT, and the disrupted NSP provision. We then looked at the number of new HIV and HCV infections that would occur over 1 year with or without both PEPFAR's provisions for OAT and NSP. The equations here might look intimidating or less so if you're really familiar with modeling, but essentially what we did is to look at a status quo, which is the infections based on if that provision of OAT and NSP was not removed, what would be the infections, which largely is informed by the incidence as well as the number of those HIV negative in each of the population groups. And then we also estimated a scenario where you are removing that provision. And these equations essentially takes into account the incidence, the population, the coverage of that provision, as well as the effectiveness of OAT and NSP in reducing HIV. We then estimated both the relative and absolute increase in new HIV and hepatitis C infections that would occur due to that disruptions over 1 year. And this was based on 1,000 model runs to ensure that we are capturing uncertainty in those data. Looking into the coverage, there is, of course, heterogeneity as well, like previously reported for pre-exposure prophylaxis. There was heterogeneity in the coverage of PEPFAR-funded OAT across these few countries that we modeled. And in 2024, PEPFAR was supporting about that 7,000 PWID to access OAT. and coverage differ across countries. And this equates to about 4/5 of the overall OAT provision across all countries. When you look at the NSP coverage, that's about half of nearly 50%, equating to about 730,000 PWID in 7 countries who were accessing NSP that was disrupted. And this data, in terms of the disruptions, is data we received from a survey that was done by the International Network of People Who Use Drugs, whom we've collaborated with. Looking at some of the results on the absolute increase in new HIV infections, in panel A, we are showing here is the overall additional new HIV infections, both overall across all these countries. That's about 3,600 new infections that could result if both OAT and NSP are disrupted for HIV infections. And these differ higher in Ukraine, South Africa, India, followed by Kenya, less so in some other countries. And in panel B, we've showing the contribution of removal of each of these interventions, where most of that new infections is probably due to NSP, which had a higher coverage. However, these are short-term projections and they do not account for secondary infections. In summary, this PEPFAR funding suspension seems to threaten OAT and could disrupt other harm reduction services for people who inject drugs. And this is likely straining fragile healthcare systems in low and middle income countries that are trying to come back into the normal from the pandemic. And really, this is a spending or it's undoing years of progress in the HIV response. There is need to diversify and localize funding to have some alternative and domestic funding, but also to integrate care models to sustain OAT and harm reduction. I would quickly speak about 2 additional case examples before wrapping up to be able to show how you can as well be able to do sort of a combination prevention aspect. And so one of the example is some work that's been published from my colleague Jack Stone. He looked at modeling to guide the prevention and treatment response. Now, there's the work that I was done by myself looking at prevention and treatment response in South Africa. And we use dynamic compartmental model, parameterized and calibrated to local data in Pretoria, South Africa. Earlier on, I did speak about the impact or the influence of homelessness, and we were able to show that if you remove the additional risk due to homelessness, you are able to avert about 34% of new HIV infections over 2023-2030. And so if you removed the additional risk, that is sharing needles as well as remove the barriers to access of OAT, then you're able to avert about a third of new HIV infections. But if you scale up ART and OAT and NSP to attain the 2030 targets, then that could avert about 63% of new infections between 2023 to 2030. And there would be additional benefits if you remove the additional risk that homelessness brings. Another case example, work from Jackson. He looked at modeling the impact of prevention and treatment interventions on HIV and hepatitis C transmission among people who inject drugs in Kenya. This is another example of a dynamic compartmental model, parameterized and calibrated to local data in Nairobi and the Coast region. That's Mombasa, Kilifi, and Kwale. In Jack's work, we're able to show that existing coverage of interventions could reduce HIV incidence by 13% and 19% in the Coast, in Nairobi and the Coast, respectively. However, if you scale up OAT, NSP, and ART, that could almost halve the HIV incidence by 2030. For instance, in the Coast, if you scale up ART, NSP, OAT to the UNAIDS WHO 2030 targets, that will be able to reduce incidence by about 2/3 in cost. And if you reduce additional risk, then that impact increases. As I wrap up, I thought it wise to speak a little bit at emerging challenges and opportunity, cognizant that we are marking the World AIDS Awareness Month. So some of the challenges and opportunities are the biomedical advances. There has been really a revolution in the HIV response, HIV prevention landscape. There's been introduction of long-acting injectable medications such as long-acting PrEPs. However, some of the challenges that still persist is uneven access by different population. There's still issues with adherence challenges. And when it comes to pre-exposure, when it comes to ART treatment, adherence is really important. There is the challenge of structural determinants. For example, housing, stability, criminalization, and incarceration, among others. These structural determinants have continued to shape the HIV vulnerability. And cognizant of that, it's an opportunity to ensure that these structural determinants are reduced to ensure that the HIV response gets on course. Then there's community-led, culturally tailored responses and systems. Community-led responses have ensured that there is improved of uptake of both prevention and treatment programs. But it also offers, when you look critically at issues around HIV funding and the declining HIV funding, then these community platforms will ensure that it offers platforms to integrate more broadly with other programs such as harm reduction, mental health, and uncommunicable diseases programs. Then there's human rights and gender equality. Without human rights and gender equality, then outcomes for HIV are always in jeopardy. And so this ensures that there's improved HIV outcomes, viral suppression, ART uptake, and so on and so forth. Areas that still needs to be looked at, issues like stigma and discrimination, punitive laws, gender-based violence, and so on, needs to be improved as areas of opportunities. Then I've spoken largely about funding disruptions that's declining, but there's opportunity to ensure that the response is aligned to domestic funding towards 2030. Lastly, I'll speak about a few conclusions here, that there is need for modeling to be central to HIV decision-making. This is critical. There is need to strengthen the data systems, healthcare, to ensure that these align and ensure that the modeling is, the modeling work is based on rigorous data systems or data that comes from systems that are really strengthened. There's need to prioritize equity and community needs, and this is to ensure that there is no community left behind, particularly the key and vulnerable populations. There's need to protect and sustain HIV funding, ensure that there's an increase in domestic funding, protect that funding that's still coming through international community. There's need to foster collaboration between academia, health sector, community, to ensure that the work that's coming all the way from the pipeline of modeling are being embedded in that collaboration to ensure that it's serving the purpose that it ought to. And lastly, there's need to support and strengthen the local capacity to ensure that the modeling speaks into the local capacity that is required. With that, I wish to thank you for listening, and I'm happy to get some questions. I thank you.
Thank you so much, Dr. Mutai, for that informative session. And now we enter the Q&A session. Please unmute yourself to ask your question or post it in the chat. And as we wait for that, Dr. Mutai, a quick one, and this follows your call to action. Which HIV prevention or treatment decisions do you think would most benefit from stronger modeling evidence? And also, what types of data do you believe are most critical for building trustworthy HIV models?
Thanks, Annie. I think in terms of looking at which interventions could really benefit. There has been traditional interventions that's heavily been modeled in my own view, and these should be mostly the primary prevention PrEP. And so that's treatment for prevention, condom programming, VMMC, and I'm speaking mostly what we see in HIV testing and so on and so forth. And so that's really been so well modeled. I think some areas of opportunities in terms of interventions are the new emerging technologies like the long-acting PrEP, for instance. Some modeling work has been done in most of the high income settings, but I think it's crucial to see how that can be done and evaluated in low middle income settings. I think another area that needs a lot of modeling is on structural interventions. It's always not as simple as you do, for example, do for modeling for, say, primary prevention, but structural interventions, looking into components of, say, gender-based violence, looking into stigma and discrimination, homelessness, that array of structural barriers needs to always be modeled. I think your other questions was it in what are some of the data that are critical for modeling, right?
Yes, for building trustworthy HIV models. Yeah.
Okay. I'll say for me, it's important to move more to routine data. Um, Routine data collected through the lowest levels and both treatment and prevention data, and whether it's through government, like through DHIS2 systems for HIV, or through community-led programs, then for me, data that's so routine helps. Most of the times we depend on survey data that are less routine, done after 3 to 5 years, and we tie that to things like systematic reviews. But if we have more routine data collected and data quality improved over the years, then that will be important both. And from from the models that we've done, there's been a lot of progress that has been done, and I commend that in the general population to streamline the data to ensure that DQAs are done, but less so in the space of vulnerable populations where data is still dependent on, say, civil society organizations that depend mainly on international funding. So that still needs to be improved.
Okay, we have some questions in the chat from Bernard Kolohoma. Does your model take into account 2020 COVID-19 and 2025, the reduction of ODA, USAID, and other foreign aid? How current is your data? How agile is your model to these changes? There are a couple of questions, but I think we can begin there.
Yeah, thank you, Bernard, for your questions, really helpful questions. And so your first questions is whether our model takes into account the 2020 COVID-19, 2025 reductions in order. So I'll say the models that we've done on the impact of PEPFAR funding cuts is sort of a snapshot of the data for 2024. And that's just a 1 year data. But then in the PrEP model, of course, we focus that to what it will mean for the next 5 years. But in our dynamic transmission models, it sort of take into account that dynamics because it takes the program data as a base. I'll say, for instance, the Pretoria model, it takes account into those changes in the programmatic data during the COVID period, where, for instance, you see a dip in OAT and NSP provisions during, say, 2020, 2021 period, slightly coming up in 2022. So for our transmission dynamic models, that's able to be taken care of. For sort of the static models, that's not being taken care of. You've asked about how current is our data. I would say we're using current data to the extent that that's available. For instance, for PrEP and OAT NSP, we used the current available data. And then, of course, we do use systematic reviews. These systematic reviews, they get updated. Some take a while to be updated, but we still think that it's relevant data. Your other questions, key populations. Let me read that.
Or we could move to another question and then we'll come back to that because we keep getting questions. So we will jump back to his third question. Is that okay?
Sure.
So there is Omaima Raraj who has asked, who has said, thanks, Doc. It's really fantastic job, very nice presentation. Small question. Through the works you have presented, almost all the analyses are based on static models. Can you please justify the choice? More additional clarifications?
Thanks, Omaima. Great question. So I'd say the first two models on the impact of funding are based on static models. The choice of those static models is based on the urgency that was needed globally to showcase some of the impact of paper funding cuts, and that needed to be done in really a quick round time around to be ensure that that data is still relevant. The work that I presented about South Africa model and the Kenya model, those are not based on static model. They are based on dynamic transmission models. And those are models that the choice, I would say, the dynamic models will take a while to parameterize. You'll need a lot of data to analyze to be able to do that. And so it depends on what we are looking into. The choice of static was because we needed something so quick and something that's still robust enough. And so I wouldn't say that just because we used a quicker turnaround, it's not robust. The estimates are robust. We've even done some secondary infections, and I'm happy to share the papers, and you can see that it's rigorous work.
Okay, we have another question from Jean Bosco. Is data quality the major challenge you had to complete this work? What is your reflection about understanding heterogeneity of HIV transmission and its implication on modeling outputs? Based on your experience, what recommendation would you provide to optimize models to be more close to true real-world situation for HIV response?
Thanks, Jen. I would say data quality always is an issue, but it's not something that we can do at our level as modelers. We can analyze that data. We can give some feedback to our collaborators that we think maybe this data is not aligning well, but then we always have options of what to use in place of that. If we think that a certain data quality if we think a certain data is not robust enough, then we always either resort to using systematic review that has pulled data across other countries. If we think some data are missing, for instance, I've said we can use, say, a low and middle income country analysis that was done elsewhere or done by our team. You've asked about a reflection about understanding heterogeneity in HIV transmission and its implication in modeling outputs. I would say it's a really critical aspect to consider heterogeneity. There would be heterogeneity across populations, say male versus females. There would be biological aspects. There will be, say, the access levels would be different. And so capturing that heterogeneity about things that come into play both at biological level, at individual, at societal level, then it's important because they impact the robustness of your outputs. You can overestimate or underestimate your results based on the choice that you made about the heterogeneity. I'm just trying to, if I'm not giving sufficient, it's just trying to ensure that I get time to answer as many as most questions, but I'll just giving them brief that way, Bosco.
Mhm.
how to optimize models to be closer to the truth. I would say there's no one method that you can use to optimize your models. And, you know, it's not necessarily that there's a certain truth. What we try to do in the modeling space is we want to ensure that what you're modeling is as close as possible to the empirical data. And so we use different research groups use different methods. For us, we'll use, for instance, a Bayesian ABC, that is a Bayesian framework, Monte Carlo framework, for instance. Some people would use a different approach, but then all what we are doing as modelers is to make sure that the data that we are generating from the models is able to, as close as possible, to be closer with empirical data. And so there will be different approaches that different groups will use.
Okay, I think we can go back to Bernard. There are very many questions and keep them coming. We'll find a way to answer all of them. Let's go back to Bernard's that question, which ties to some of the things we've just talked about. Key populations are important, but the high transmission also occurs in children, 0 to 14 years. Are there any efforts present future to give holistic view by including this demographic?
Absolutely, Bernard. I think what of the key populations that we've modeled is based on the data that we have that shows that most people in the key populations are, of course, adults, perhaps 90 or 18 years and above, or slightly lower than that. But then this is based on the analysis that we do to ensure that are we capturing the median age or the mean age or the whole age of the key populations. But there are models that have adequately captured the children dynamics. For instance, in Kenya, nationally, they're using the spectrum model, which has both the adult and children, and is giving a whole array of key HIV outcomes for children, including new infections, age-related deaths, how many are on treatment, how many infections are occurring in children, what interventions can be done. And so those models for pediatrics are there. But then at the national level, I think there's still more that people can do to just have standalone models that are not necessarily the national models.
Okay, another one from Titus. In the course of your work, what would you say is the single most critical intervention in the fight against HIV? What's the biggest challenge modelers should be aware of when working with HIV data, and how did you overcome them?
Fantastic questions, Titus. I would say there's no, you know, a size fits, like an intervention that you'll say that this is the most critical intervention that's a game changer. I'd say we'd always advocate for combination prevention, and also there's an element of choice. But I think what's critical that's coming up that's going to be a game changer really are the injectable pre-exposure prophylaxis. One of the aspects that has been both as a treatment and as prevention, one of the difficult things that has been there is, and this causes things, for instance, like treatment failure. So treatment failure. Things have been something like adherence to medication. And with injectable treatments where people are just getting 2 injections per year, in addition to some oral medication, that's a game changer and shows that probably as the prevention evolve, then in the future, you can maybe have a chance where you only have 1 injection per year. That's an annual injections, and then additional oral treatment. And I think that would be a big game changer because when we tackle the adherence issues, then we improve uptake. What's the biggest challenge modelers would be aware when working with HIV data? Well, I think the biggest challenge is to ensure that the data you are using is representative of the population that you are modeling. If that data is not representative of that population, then it might, and again, it depends. If you looked at survey data, I'll say ensure that it's representative. Take into account the survey methods, how were they done. Is it, for instance, population level? Is it for select populations? So there are some bias in how populations were selected, because that one can give you a biased, either higher prevalence, lower prevalence, that your models will be struggling. If it's program data, just look at the data quality that's been put into place, whether if you're given treatment data, do you think it's overestimating that your model may not reproduce that? And I would say most importantly, you just have to have a working and collaboration with your stakeholders, because as modelers, you may not be in the field, but you have those collaborators. So make sure that you have good relationships with your collaborators.
Okay, we have another one from Swathi. Really fraction differential equation needed to model this transmission. What should you prefer to model the disease? Is that clear?
Well, I would say we've used in our transmission dynamic models, and I speak about two in my slides, and I get just for clarification to the audience. On paper funding, we've used a static model. On the example that I presented for our South African HIV transmission model and our Kenya HIV hepatitis C transmission models, those are dynamic transmission models that use ordinary differential equations. And I think people, you can use any other method that you think it will answer. For us, we use ordinary differential equations in those dynamic transmission model. As long as you still reproduce the epidemic as empirical data suggests, then that should be fine. I'll also point out that there's been effort by different modeling groups, like in our research group, alongside other research groups. We often publish these model comparison papers that tackle the same issues using different models, that use different assumptions, use different, perhaps maybe data. And we always try to compare how close do they. Oftentimes you find that they're really close. So it may not matter much, but as long as you are able to justify the assumptions you are making, as long as you're able to ensure that the data that you're using is robust and rigorous, that should be fine.
Okay, another one from Joki Kemani. In light of the funding cuts and the increasing need to integrate HIV services delivery, what key data would be needed to model whether integrated service delivery can sustain program outcomes?
Great question, Joki. So in terms of the data that you need to integrate HIV service delivery, so I would think of this approaching it at looking at, say, 2 or 3 models of care where you have, say, and I'll try to give some examples here. Say you want to integrate HIV and hypertension and diabetes screening, then you will need data on what would be the standard of care. That's business as usual, where probably it's a standalone HIV services. And so you'd need data about how many people coming into that program. And if it's a prevention program, for instance, you'll need to show the numbers for that matter. Then you'll need another arm that probably is where you are integrating services, and you'll be doing screening of HIV, screening of hypertension, and you can now think about an outcome. An outcome, for example, will be either if you do the integration, it could be, is it in terms of funding, is it cost saving? In terms of HIV outcomes, can you say maybe it's reducing new HIV infections because you're able to diagnose people early, that maybe someone was just coming for a diabetes and you screen them for HIV and you are able to identify that perhaps they were HIV. And so you've improved in terms of, as a tool, you've use that to be able to improve early diagnosis of HIV or early diagnosis of NSIDs among people who are HIV for that matter. And those are the kind of the data that you need both for the different care models of care. Look at the outcome, look at the cost data as well, and you can be able as well to show whether it's cost effective or not.
Okay, and as we wind up, we can go back to Bernard's fourth question, which was based on the models. Are there areas where we can do more implementation, science, programming, or research and development to accelerate progress towards 2030 targets? Does it provide granularity as opposed to blanket approaches?
I would say yes. There are areas that implementation science can come in. I'll give an example, for instance, pre-exposure prophylaxis, where you'd find maybe those studies may start off being implemented for general populations where new tools that are coming, new prevention tools that are coming in first would be shown to be efficacious and shown to be safely in general populations. And you can have other implementation studies to show if you implement that tool among a certain population that initially was not in the mix when that was being shown to be efficacious and safe and people are able to take it, looking at acceptance to the prevention tool, then those are areas that you can be able to say, this has been shown to be working for this population. We want to use implementation studies, not necessarily to show that it's efficacious because it's been shown and we think that was robust, but we want just to show whether it's acceptable among these populations, what would be the most feasible implementation pathways, and that's where implementation sciences and studies can come in for different treatment and prevention options. What was the second question, Annie? There was a second question tied to that, Annie.
Hello. Oh, yeah. Does it provide granularity as opposed to blanket approaches?
Yeah. So most of our models, we try to be as granular as we can. And other modelers, of course, do the same. We try to be as granular as we can. We take into account, we always discussed what are some of the risk factors, and this depends on context and population groups. A risk factor can be, first thing is to ensure that it's as granular as you can in terms of sex and where possible age. You look at things like race. Is it a matter? In a place like South Africa, for instance, race could be a matter because not just race as a standalone, but as a predictor of the different levels of access to, say, opportunities like economic empowerments and so on and so forth. It could be, is incarceration an issue? So we try to be as granular as we can, looking into both the social demographic characteristics as well as the structural factors that affect the transmission of that disease. I've seen Peter Mbugua asked about Bayesian modeling.
Yes, maybe you can answer that as we now wind up.
So Peter, what we use is what I'll call Bayesian sequential Monte Carlo approach to fit our model into the data. I'll try to somehow break that down to say we'll have a model will produce some results, but then there's data that says, for instance, HIV prevalence among female is 40% or 10%. And we'll be using this Bayesian sequential Monte Carlo approach is to be able to ensure that it tries to change most of the parameters that we are supplying to model to ensure that the model output is as close as possible to that observed. And so we supply it with some priors, some will be informative, some of the priors will not be informative, and we try to ensure that we get kind of reliable posteriors through that process. And we also do validate our models. We can either validate it with empirical incidence estimates that are available, which we don't fit into, or something else that we did not fit into, but we try to compare how is our model being able to generate some of the results closer to something that we not fit into. Thank you.
Thank you so much, Dr. Mutai. And as we wind up, because all of this is to ensure that we have actionable insights. So could you tell us what makes modeling results persuasive or unpersuasive to policymakers?
So good question, Annie. What really make modeling results persuasive? First, I'll say it's the process itself. If the process is something that we, the modelers, did it somewhere in mass and then come to earth and tell the policymakers, alas, here estimates, use them, they're fantastic. And no matter how we try to flower that, it may not sell to policymakers. What I'm trying to say is what make it be actionable is if you involve policymakers from the design phase to its implementation. What also make it appealing is when it's grounded in sound epidemiological data available locally, as well as that which is not available. And so another thing that I would mention again is how we explain this to policymakers. If we use jargons and that kind of stuff, which I'm sure I can attest that I've used here, then it's not going to sell. And so reducing the jargon when we are dealing with policymakers, ensure that we involve them and ensure that it's embedded in the local epidemiology data as much as it can.
And I see Njoki has a follow-up on that. And could you address that as we wind up? I
Sure.
know I've said this a
Sure.
couple of times, but this
Sure.
time for real.
Sure. Thanks, Njoki. I think I was trying to squeeze in slides, but there were good examples of some of the work that our team has done that has informed policy. There's work that our team has done both at modeling level as well as through global systematic reviews that has informed some of the WHO guidelines. And so I'll speak, I think, the 2021 guidelines on viral hepatitis C. That's one piece that you'll find some of the work that was done, both modeling as well as systematic review that has gone into that. There's recent work from but 3 of our PhD students that they did some systematic reviews, and that's also been fed into modeling to show the different structural factors, impact of different level of stigma and discrimination on HIV response. And that one has involved it came out in the 2024 UNAIDS global report. And so I'd say around UNAIDS, WHO guidance on HIV and on viral hepatitis, as well as regionally here in Europe, there is the a regional body looking on viral hepatitis C. Some of our modeling work has been able to inform that. It could be, for example, not necessarily example, but these are things that have been able to inform policies, work on the importance of incarceration among people who inject drugs in hepatitis C transmission. That's one of the work that's been done. Other is the importance of homelessness as a structural factor, importance of stigma and discrimination as a structural factor, and all of those have appeared in UN's WHO guidance. I thank you.
Thank you so much, Dr. Mutai. And thank you all for joining us today as we saw how well-designed modeling can transform complex HIV dynamics into clear, actionable insights that strengthen prevention, treatment, and policy decisions. We hope you found the session valuable. A big thank you, Dr. Mutai, for sharing your expertise with us. It was such an informative session, and we truly appreciate it. I wish you all happy holidays, and I look forward to seeing you in our next session in January. Thank you. Thank you so much, everybody.
Thank you so much for listening, and thank you, Annie, for having me, and Sima.
Thank you. Hello, everyone, and welcome. I'm Annie Njanja, a communications specialist